Hi there, Melanie Grant here, and we're taking a look at office and other outpatient services as we focus on our medical decision making with the new 2021 guidelines. To start, let's look at activity number 1 that we look at with our Evolve visits. I'm going to share my desk. Let me just limit some stuff right here. So I have here a worksheet for Chapter 11, Activity 1, where we'll be matching some of the terms that we just learned in our previous video with medical decision making. The importance for this is to be able to look at these and identify the correct level of service based off of what we're looking at here. So let's get started. Our first one is a high medical decision making. So I can look and say which of these levels of service has a high level of medical decision making. If you're familiar with the different leveling of medical decision making, you'll know that a high level is going to be either a 99205 or a 99215. And we can see that here based off of the level of medical decision making for a 99215. In fact, this chart's just looking at what level of medical decision making we will use. Our next one is a straightforward medical decision making. Again, we want to go to our chart to pull up which level of service, a 99202 or a 99212, that has a straightforward medical decision making. And here we would see 99212 on our list, and that would be our answer for number 2. For moderate medical decision making, we're going to be right out of 4, which puts our low at 99213, number 5. The one that we skipped here was number 4. May not require the presence of a physician. And you'll remember that the level 1 visit is a nurse's visit or requires no provider in the office. What a fun activity. So I think that last one was maybe a little too easy. So I've brought up for Chapter 11, Activity number 4, for us to look together at a clinical note for an outpatient visit where we determine the level of medical decision-making and thus the level of E&M code. Let's take a look at this one together. I'm going to use my highlighter as I put this in PDF because that can make it a lot easier for me. If you don't have a PDF editor where you can highlight, you can also pull this directly into a Word document, or you can print it out and highlight it by putting it inside of a plastic sleeve. So here I have a clinical progress note, which tells me at the top that it's located in an office outpatient setting. I've determined that the type of visit is going to be somewhere between a 99202 through a 99215 for my office and other outpatient services. I also need to determine if this patient has been seen before, which will identify the type of service. The patient's name is Kendra Sparkling and it's seen by Dr. Gall. Kendra is a 7-year-old. I'm just going to highlight that because every time I see a pediatric, I look to see if there's a documentation of another person indicating history for the patient. She was seen just last month. So as soon as I see that, I know this patient is going to be established outpatient visit since she was seen within the last 3 years by Dr. Gall. She comes today with a bad cough and she's had for more than 1 week. It's definitely worse at night, however present all the time. It's quite harsh and she's having a productive sputum that is green. She has had a low-grade temperature and has not really felt very well. You'll notice that they've told us it's a problem-focused history, and they're absolutely correct because they're looking at a lot of details of her HPI, but there's no review of systems and there's no history besides the fact that she was seen a month ago, but they didn't tell us what for. Also, you'll notice that history is no longer required for the level of service for medical decision-making. So the only things that's really important for me is, did we look at any data when we were reviewing for this patient? Was there any additional complications that we maybe looked at? And the fact that they're established. The physical exam now reveals that both tympanic membranes are normal, her nose is clear, her throat is clear, but her lungs are really coarse in both bases. There's an occasional wheeze, and her heart has a normal sinus rhythm without murmur, which is documented as an expanded problem-focused exam. Again, this is great information, and they're absolutely correct because certain levels of the exam, we're looking at the specific problem and a few different areas around that problem, but nothing that's identifying anything that would affect the medical decision making for me today. The impression is acute bronchitis. This is important because this tells me how many problems we are addressing, and this is the diagnosis that we would be using for this visit. We also have a plan for prescription for a Z-Pak, and we have the details here. So the Zythermax Z-Pak liquid is given with 200 milligrams per 5 cc's, 2 teaspoons daily, then 1 teaspoon daily for following 4 days. So that's all part of the prescription detail. We will see how she does. If she has difficulty next week, we will recheck her. So there's nothing in this indicating to me that we're uncertain about her prognosis or that we're concerned about her prognosis. In fact, it sounds for the most part that we expect this ought to make her feel much better once she starts getting that medicine down her throat. Medical decision-making, well, it's even told here that we're looking at a low complexity. But let's break that out and see how we would have selected a low medical decision-making. I'm going to go to my other chart and see where it disappeared to. For my medical decision-making from the AMA. If it'll ever come to this screen. Here I have a patient. Now keep in mind that we said it was a low medical decision-making, which off the bat for an established patient is a 99213. But we also want to verify that what the provider is saying is low medical decision-making is always accurate. And so we'll look at it ourselves to make sure we're coding the most accurate level of service for the patient. They're seen for one acute uncomplicated illness or injury. I would not document acute bronchitis as a chronic condition or a condition that is complicated based off of how the provider indicated in their note. It seemed pretty straightforward on what the medical treatment was. And we can always look at our definitions in the E&M guidelines to see how this level would be considered acute uncomplicated. I did not notice any tests or documents being ordered by the provider. I did not notice anybody else talking to the provider with the 7-year-old, although as a mom of a 6-year-old, most likely mom gave the information or even dad. But it doesn't seem like it was necessary for the provider to document. Keep in mind, if it's not documented, it didn't happen. So even when it's obvious that the patient's not giving the details, we can't identify additional individuals giving documentation of history unless it's stated in the note. So based off of the amount of complexity and data reviewed, I have none. And so I would not meet any qualification for any level of data or complexity to be reviewed. And obviously, I had a few issues with my highlighting, but that's okay. My last one is levels of risk and complications. And you'll notice because the provider gave a prescription, it doesn't matter what the prescription is for. In this case, the Z-Pak is a prescription you would not be able to get over the counter, but sometimes you'll even see kids getting prescriptions for medications that are available over the counter, primarily because different doses are available from the pharmacy that would not be available directly. Different routes of administration may be available that would be beneficial to a patient who does not swallow pills very well, or patients, especially under Medicaid, may request to have a prescription because it will be covered under their medicine plan, but not covered for over-the-counter medicines. Regardless of the reason the provider gave a prescription, our job is simply to track that a prescription drug management was done, which simply means to say that a prescription is indicated and what to do with it is on the chart. So for all new prescriptions and any documentation to continue or change current medications would capture moderate for risk of complication. That being said, you'll notice that we have one of the three columns needing a moderate level of medical decision making. But because this is based on 2 out of 3 of the different columns of medical decision making, we instead have a low medical decision making, which does conclude with the same information our provider gave us. And so this would be a 99213 for an office outpatient visit that is established with a low medical decision making. Let's go ahead now and resume our review of different activities found for Chapter 11, looking specifically at office and other outpatient services. As we go through these, we'll take a look at all of the activities for a couple of Chapter 11 to see if we can identify the type of service as we go along. So I have here in front of me Chapter 11, activity number 5. Here we have a patient who's come in the outpatient clinic, and so this will be an office or other outpatient service. The patient is Sonia Jackson, who is seen again by Dr. Gall. I want to know if this patient is new or established and the type of service that they're receiving. So I'm going to look at their documentation. They're coming in for a sore throat and has had it for 2 days. She's not had a postnasal drip. She has tried other decongestants. It doesn't help. Because of the pain, she used Tylenol and ibuprofen. This is no real significant reduction of pain either. And the review systems are negative other than a sore throat. The patient does not smoke. So one thing I will say is that Dr. Gall did give us a very detailed history, and that's very good when determining the level of history. We can tell that because there's 4 more elements of HPI. There's a couple of questions about review systems and the statement that all others are negative, and also some history about the patient themselves saying they don't smoke, so that's not why they have a sore throat. There's nothing in here that's telling me if this patient is new or established. So if I was looking for this information, I might need to query the provider or look further in the notes. Of course, I'll want to make sure to look further in the note I have in front of me before I select the level of service. But if you're having an issue determining this patient has been seen in the clinic, and this would be informed to you if you queried the provider, if you're unable to find it from the record. On exam, she's pleasant and no acute distress. Tympanic membranes are intact, sorry, they're there. Her eardrums are there, they're not inflamed. Her pupils are reactive to light. Posterior oropharynx is erythemaceous. That means that she has a little bit of redness in her throat. She does have what seems to be bilateral tonsillar exudate of a mild amount. Neck is supple, and there is some mild to moderate anterior cervical adenopathy. That just simply means that there's a little bit of swelling in the cervical part of her adenoids, and the tonsils themselves have a little bit of gunk around them. They're a little gooey, doesn't look too great. Lungs are clear, heart sounds are regular. And so we have documented a detailed exam, which is appropriate per the provider's need. Clinical strep pharyngitis is listed as the diagnosis. And the plan discussed for treatment of the patient includes pills versus an injection, and she was given a script or a prescription for penicillin. She has a lot of throat discomfort and was given Tylenol with codeine, 1 to 2 each 4 to 6 hours as needed. Number 12, no refills. That's all the details of the prescription. She's also warned of the sedative nature of the codeine. Follow up if her symptoms worsen or persist. And the provider states medical decision-making was low complexity. At that point, that's all that's on here. So I would definitely look to query the provider to see if this patient was new. However, from the documentation and from our golden rule of medical coding, if it's not documented as the more severe, which is new, then it didn't happen. So I would automatically default to an established patient if I had no other way of determining. To go to my medical decision-making chart, well, I should clear it off from my previous visit. We have where the providers indicated this patient is here for a low medical decision-making, which is a level 99213 for an established patient. But we'll want to make sure to go through ourselves to see what we can find. For a clinical strep pharyngitis, that would be an acute, uncomplicated illness. There's nothing indicating that it was of concern or that it was uncertain prognosis that might fall under undiagnosed new problem or acute complicated problems. And so I would continue on. I'm a little surprised that the provider did not order for a strep test either in the office or even in the office with a follow-up to see if she actually has strep. Most providers will do that, but this particular one just decided to give her penicillin. That would be a quality concern if I was looking at this from a QM standard for quality matters, because I would say that we should not be giving antibiotics to a patient that we weren't sure if they had a need for an antibiotic. Now, when he said that it was clinical strep, that means that from the diagnosis, Dr. Gold felt very confident without needing to do additional testing that this looked like strep. And so for that reason, it would depend on our office, not the coders, to identify areas for quality assurance and see if this was needed to be looked at further. For us right now, all we need to do is learn about coding. So I would continue on as needed. And I would say there's no test that I could see. There is no independent historians. There are no discussion of management or test interpretations. And so that kind of qualifies all three of the categories that would fall under data and complexity. And so I have NA or none. Which takes me to the risk of complications. Since the patient has a prescription drug management, that automatically brings the risk of complications to the higher level of moderate for risk of complications and morbidity or mortality. However, with only one of those three, just like I had on my last visit, I want to remember that a moderate level of risk also includes a low level of risk and the requirements for a minimal level of risk. And therefore, the one category that has 2 of 3 is going to be the low medical decision making, which agrees with the provider and would be coded as a level 3 or a 99213. I'm going to go ahead and clear off my board and we'll look at the next one together. So our next patient is going to be our activity number 6. And we have again here a clinical progress note for the location in an outpatient clinic. This is going to be for patient Janice Snow, also seeing Dr. Gall. Now, in this note, like his first one, he has indicated that the patient was seen in the past. And so we know that this is going to be an established patient, not a new patient. Today, she comes in for 2 concerns. First is a recent prominent cough with sore throat. It is productive at times and complains of fever and chills. The second is that the patient is in for a recheck on depression. She's noticed no improvement of problems since starting the Zoloft and has been on 50 milligrams for 2 weeks and 25 milligrams for the first week. Okay, so we have a couple of details here. Number one that I would say, and what I noticed is the doctor didn't give us detail as to the level of history. That's okay, we can look at it together and see that she's coming in for a cough. We've got a description of the cough and associated signs or symptoms. We have information about product, the type of cough or the quality, and that she has chills, and that they're modifying factors for her depression. She's not noticing any improvements. So there's a lot of HPI elements in here if we were looking at those elements for other types of services. I like to point them out even though it doesn't affect the level of service for this visit, because it might if we look at other services. There's no review systems or history, and so this would still not be a high level of history. The exam looks at her weight and her pulse and other vitals that are taken. Her funda is benign, pearly normal EOM, so they're looking at her eyes. The tympanic membranes are benign, so without problem. Benign simply meaning not problematic. Pharynx is slightly erythemaceous. The neck is benign, and there's no anterior or posterior nodes. Her heart is S1-S2, and lungs are clear. So this is a very brief exam. And you may notice later on in the note that there was a lot of time spent discussing the complications of her depression. And that's why the provider didn't spend as much time in documenting some of these details. And it's not necessary for a level of service. So this would be a problem-focused exam. We have two conditions or problems addressed. There's discussion of prescription drug management. She's going to be coming back in 6 weeks, and if not marked improved, they'll consider switching the medication at that time. If there's any problems, she'll return to the clinic. She's also going to be starting amoxicillin. Again, another antibiotic without an indicated reason for bronchitis symptoms. Keep in mind, bronchitis is an infection in the lungs that can be caused by viruses or bacteria. And whenever we give a patient any kind of a prescription for antibiotics, we really want to have an indication that the patient is experiencing a bacterial infection or has had a very long infection on the virus, as that will oftentimes indicate that it is bacteria and not viral. But again, it's not our job as coders to question that for the providers unless our offices have it set up where they want us to question these things. She will push fluids and she will use Robitussin AC if needed for the dry cough with appropriate precautions and follow-up for this if also not improving. So as a coder, what I might actually go back and say is, hi, Dr. Gall. I might send a query and say, hi, Dr. Gall. I see for your patient, Janice Snow, who was seen on such and such date, that a diagnosis for acute bronchitis was indicated and a prescription for amoxicillin was listed. In your note, there was no indication as to the type of bacterial infection. Was this tested and or was this something that we can confirm for this visit? That would be a query that I might set up and might even list additional diagnoses that are optional for listing the type of bacteria to support the treatment that was done on this day. But regardless of that, and most likely in most cases, our office will not be tracking for that. So we see here that we have two problems that are being addressed, prescription drug management for both of those problems. There's also time documented here of 45 minutes with Janice today and 25 minutes on her counseling. So there's a total of 45 minutes with 25 counseling for the depression. When we look at our medical decision-making chart, it's important to look at a couple of things. Number one is that time's not listed on this particular chart. That would instead be tracked on the regular tracker, which we'll look at in a minute. For the level of service for Janice, she did have two conditions that were reviewed, one which was acute, uncomplicated, and one which was chronic and not really indicated in the note as unstable. I might look back and see if there's any details indicating that there was some sort of exacerbation or concerns with treatment, but it even said that she noticed no improvement of problems since starting the medication, but it doesn't say that it's progressing or getting worse. And so when I look at the difference between a stable chronic illness and one or more chronic illnesses with exacerbation, progression, or side effects of treatment, I'm looking at the documentation that it is not getting better and or it is getting worse. It actually does say there's no improvement. So I would put this under some exacerbation or progression, as opposed to stable chronic, because it's not entirely stable until we've gotten to the point where it is no longer progressing. There were no tests ordered by this provider today, nor any other areas of complexity. And for risk and complications of morbidity and mortality, we have prescription drug management, which puts us to a moderate level 4 visit for this patient for the medical decision making. However, I also want to take into consideration the amount of time that is spent, and keep in mind that time is based off of all time with the patient in the office setting that is either pre, post, or during the visit. And so we only go by the total number of time for office and other outpatient services. That would be 45 minutes. I'm going to look in my office and evaluation and management services. So that I can look at my table to see exactly how much time 45 minutes would fall under. Keep in mind again that we had our moderate medical decision making, which is a level 4. However, 45 minutes total spent with the patient falls under a level 5, 99215 for the amount of time. And since the medical decision making or time can be used, we go with the highest documented level of specificity, which is our time-based coding at 45 minutes for 99215. Let's look at our next one for activity number 7. Here we have an outpatient clinic. The patient is Judy Clark, who is seeing Dr. Martinez. Under the chief complaint, it says that they need an annual GYN. So as I start to look at this, I've identified that they're in the office and other outpatient setting. Despite the fact that they may be new or established, which in this case, if it doesn't tell me that they're new, then I would default to, if it's not documented, it didn't happen, and so therefore they must be established. However, the type of service is not an office service. It's a specialty visit called a GYN exam or preventative visit. And I would therefore go to my evaluation and management section for preventative services based on the age of the patient. I would also look to see if the GYN exam should bill under a Medicare service if they were over the age of 65. Since she is not over the age of 65 and it is specified as a GYN visit, that would bill to an evaluation and management service for preventative services, patient age 59, 99396. None of the rest of these details would be necessary unless there was additional documentation of an additional service. To find that out, I would want to look at both my history, my exam, and my diagnoses. Honestly, a diagnosis of menopause and annual GYN indicates to me that there's no additional office visit, because the GYN will include any age and gender appropriate discussions and conditions that are also treated at the same time. I can look and see if there's any specific details that might support a higher level in addition to the E&M for the GYN, but most likely I'm not going to find that. In fact, when I look at my history, I see that she is on medications for 2 years, is not having any hot flashes. was believed to have gone through menopause, and was on some low dose of estrogen. Feels fine today. So there's nothing specific saying that there was an additional complaint that was reviewed. Therefore, this is only going to be an annual GYN, coded based off of age and the fact that she is established to code 99396. Let's look at our next one. Our next one here is an evaluation and management service for a home visit. Since this is a home visit, I'm going to go to my office or my home visits, E&M services under home, and look for the appropriate level of service based on the fact that this is an established patient and based off of the documentation that's indicated. Since we're looking at office and other outpatient services, home visits would not fall under those. So I'm going to skip this one now, but make sure you do this in your assignments. Activity number 9 is an office visit for an established patient. And they've told us that off the bat. This is an 82-year-old man, which automatically when I see 82-year-old, I know that I want to look and make sure there's not a Medicare service that would apply if this was some sort of preventative visit. He visited his family practitioner concerning his adult onset diabetes mellitus. Well, that most likely is not preventative. He performed the patient glucose monitoring and had blood glucose tests performed every week at the local hospital. So this is all history about him, not services that we're talking about doing or even that we reviewed. According to this note, this is just detail of what he's done in the past. It was becoming evident that the man had to be switched from an oral medication to insulin due to uncontrolled diabetes. Again, I see this term here, but that doesn't mean that the current visit is uncontrolled. This is all part of the history. In order to be certain, the physician performed a history and physical exam. At this time, there was a limited number of diagnoses and treatment options for the physician to consider. So now that the narrative has changed, this tells me that in fact, it is evident, this is part of today's visit. This narrative is not exactly from the provider's perspective. At this time, there was a limited number, I reread that, diagnoses and treatment options from the provider to consider, and he had a limited new data to review. Since this summary actually doesn't give me the details of the medical decision-making, I can't break this up on my medical decision-making chart. So I'll have to go off of the summary that tells me this is a low medical decision-making, which codes to a 99213. Our last one here for activity number 10, chapter 11, is identified first as a consultation. The first thing that I notice is that he's consultation and that he's a 74-year-old patient, which means that he most likely is covered under Medicare. Keep in mind, Medicare does not allow for us to bill consultations, which is a billing guideline, not a coding guideline. However, he's referred by third-party payer for a second opinion regarding his primary osteoarthritis. So what this tells me right here is that we're still looking at consultations because it's not billed based off of Medicare services. Third-party payer means somebody other than Medicare is referring him for a consultation. Again, even if it was Medicare that was the third-party payer, this particular patient would be billed as a consult when we're looking at the correct level of service for consult. Now, there's a few things I want to look at to make sure this is in fact a consult and not a regular office visit. Number one is that it was referred by somebody other than the provider the patient is seeing, and it wasn't just the patient who wanted to see the provider. In this case, that's already identified. Number two is that the patient is receiving some sort of consult from the provider they're seeing. And in this case, the consultant seeing the patient at the insurance company's request in the office has never met the patient before and did in fact perform an extended history, complete review of systems to identify a comprehensive history, a comprehensive physical exam, and review of x-rays and films, so on and so forth. The last two things that are required in a consult is, so he did provide the consult. He did provide a service to the patient. The last two things are that the consultant sent a response to the original requester and did not take over care. So here we have the consultant agreed with the diagnosis and thought it was osteoarthritis, that it would progress and leave the patient with more disability in the future. Again, this is more of a summary of the visit, not the visit itself. So we can only presume that the rest of that for a consult was in fact reviewed. And the medical decision-making here is moderate. When you're doing your review of this one, since it is a summary, you're only going to be looking at details that identify the level of history, the level of exam, and the level of medical decision-making for consultation code. When you look at those three together, you're going to get to code 99244 for evaluation and management for consultation. Now I have a note here that a modifier would also apply for this. And I want to look at my E&M codebook to see why. So according to the E&M codebook, CPT codebook, under modifiers for E&M, a mandated service, which is a service required by the insurance or another provider, such as a lawyer or a judge rather, would be indicated with modifier 32 to show that it was in fact mandated by somebody other than the patient or another provider. That's it for our activities this week on Chapter 11. How did you do as you followed along? Did you have some issues, or were you right along with me as you were coding? Make sure to re-review the ones that had complications or difficulties and look along in the book to see where we found some of those details. If you need additional practice, there's also practice that can be found in the workbook that's associated with the Carol Buck Step-by-Step Medical Coding for 2021 edition. I highly recommend this because it gives you a lot of examples and practices in addition to actual op notes that you can review in more depth. That's all for today, but we'll talk to you next time.